Hello, I'm Marilyn Albert, and I'm going to be talking to you about new approaches for the diagnosis of Alzheimer's disease. I'm going to be covering three topics. First, I'm going to give you a brief overview of the evolving concept of the continuum of Alzheimer's disease, then try to describe to you the rationale for the increasing focus on the earliest phases of the disease, and then a little bit about how people are trying to use biomarkers to improve the accuracy of diagnosis, especially in the very early phases. When work in Alzheimer's disease began in the modern era, in about the 1970s and 80s, the major focus was on people with clinical dementia, Alzheimer's disease dementia. And a great deal of work was done in that area. There was a great deal of effort trying to see if we could diagnose people with dementia more accurately, try to understand the changes in the brain, and ultimately that led to the generation of several drugs that are now on the market for treating people with dementia. These drugs make people slightly better than they would be without them, but they don't make a dramatic difference in course. And so over many years since then, there have been major efforts to try to find improved treatments for the disease, and these have not been successful. So that has made people wonder exactly when in the course of disease would be best to intervene. During the time that people were working very hard on looking at individuals with dementia, they began to see patients who had progressive mild difficulty with memory, getting worse over time, changes in other kinds of aspects of cognition, and yet they didn't meet criteria for dementia. And ultimately, a term was developed for these individuals that many people use today, which is called mild cognitive impairment. So over many years, we've been thinking not only about people with clinical dementia, but people with mild cognitive impairment, or MCI. And people trying to think about interventions and treatments for the disease began to think about treating people in the MCI stage of the disease. But an unusual thing happened while that work was going on, which is that many of us in the field began to see people who were normal, and when they died and they came to autopsy, about 30% of older individuals turned out to have the hallmark neuropathological features of Alzheimer's disease, what we call amyloid plaques and neurofibrillary tangles. So what was unusual about this is that the plaques and tangles were quite widespread in people with normal cognition, but they did not have neuronal loss. And that suggested that perhaps the earliest phase of the disease might be the time that you might want to intervene, when there was a more or less window of opportunity before neuronal loss had begun. So there's an emerging consensus in the field that Alzheimer's disease has a long prodromal phase, likely a decade or more. There's a consensus that there are individuals who are symptomatic for many years prior to the time that dementia begins, this MCI phase. And there's a consensus that Alzheimer's disease pathology exists without neuronal loss among some individuals with normal cognition, possibly as much as 30% of individuals who are older. And with the fact that there were many clinical trials that were attempted both in individuals with dementia and in people with MCI that were negative, there's the increasing concern that late intervention may be less effective, and we need to try to improve our capability for early intervention. And so this has led ultimately to the notion that we need to think about the continuum of the disease, and we need to think about the optimal time to intervene, and we need to think about the best drugs for each stage of the disease. So we need to think about trying to find better treatments for people with full-blown dementia, people with mild symptoms that are not yet demented, people with MCI, and even possibly intervention when people are cognitively normal but are beginning to develop these changes in their brain that we associate with the development of Alzheimer's disease, the preclinical phase of Alzheimer's disease. And of course, what this means is that if you were going to treat people with full-blown dementia, you would be thinking primarily about treating symptoms, trying to slow decline. If you were treating people with MCI in this prodromal phase, hopefully what you would be able to do would be to slow progression to dementia. Maybe somebody could live out their lifespan with mild impairments and never become demented. But if you could intervene really early when people were cognitively normal, then you could prevent the onset, hopefully, of any symptoms at all. And this is what people are trying to think about right now in research areas around the world. But of course, there are a lot of diagnostic challenges about early treatment and early intervention. The boundary between normal function and symptoms of early disease are very, very difficult to identify. And we know from experience that early diagnosis is much more often in error than when we diagnose people who have full-blown dementia. So the people in the field have been thinking about additional information that they might look to improve the accuracy of very early diagnosis. And this is where biomarkers have come along. So in 2011, the National Institute on Aging and the Alzheimer's Association in the United States gathered a group of individuals to try to think about some new ways to improve diagnosis. And one of their primary recommendations was to try to incorporate biomarkers that would tell us what's going on in the brain and hopefully increase our accuracy of diagnosis. There are two categories of biomarkers. One category has to do with measures that are related to the molecular pathology of what we call the amyloid beta protein. This is the protein that makes up the plaques that are in the brains of patients with Alzheimer's dementia. And you can measure that either through cerebrospinal fluid, or now in some places you can use amyloid imaging to see amyloid in the brain. The working groups also recommended thinking about biomarkers related to neuronal injury. This might include cerebrospinal fluid measures of tau or phosphorylated tau, which is the primary component of the tangles, which are seen in patients with Alzheimer's dementia. But there are also ways of measuring brain structure with magnetic resonance imaging, or brain function with positron emission tomography or single photon emission computed tomography, ways of looking at the structure or the function of the brain. And the notion is that if you could use this information in addition to the clinical diagnosis, perhaps you could get more accurate. So if you were going to apply this in a research setting, you would evaluate a patient in the standard manner, the way we would today and the way we have for many, many years. But to try to increase your accuracy of diagnosis, you would use information from these biomarkers. As I said, biomarkers related to the amyloid beta protein or biomarkers related to neuronal injury. And the concept is that if you had one biomarker from each of those categories that was positive, then you would have a high likelihood of having Alzheimer's disease. If you had only one of the two positive, you would have an intermediate likelihood, and if neither of these were positive, then you would have a low likelihood of having Alzheimer's disease. Now, this is just proposed for research, but all around the world, people are attempting to see whether or not this approach can be used to improve early diagnosis of people with Alzheimer's disease. So where is this going? What we would like ultimately is to improve the accuracy of diagnosis for individuals, not just for groups of people, but on an individual basis in the earliest phase of the disease using a combination of clinical evaluation and biomarkers. If we could do that, then that might help us develop better treatments for Alzheimer's disease, because it would allow us to intervene earlier, identify people at risk, and try these treatments much earlier to hopefully prevent or delay the progression of the disease. And if you think about it, this approach to Alzheimer's disease is really very similar to the way we've been thinking about heart disease for many, many years. If you went to the doctor and the doctor told you that you had high blood pressure or high cholesterol, the doctor wouldn't say, well, we'll wait until you have a heart attack or a stroke before we treat you. They would use these risk factors to say, you know, you're at risk and now we want to treat you. So this is the basic notion that we have for Alzheimer's disease, to identify those with risk factors, treat them early in the hopes of delaying the onset of the debilitating disease that we all wish we could end today. Thank you very much.